Hello, my name is Amanda Baynard, and I will be completing a policy analysis on refugee health assessments provided in health departments. When discussing policy and ethics in the clinical setting, there are four basic principles to consider. These are autonomy, which involves showing dignity and respect for yourself and others, non-maleficence, which is preventing harm to those you are caring for, beneficence, which requires one to do good on behalf of others, and justice, which is treating all individuals equally. Ethics and policy work hand in hand, but they are not the same thing. Policy and procedure sets forth a guideline of what should be done. However, when that policy falls off or becomes ambiguous, that is when ethical principles and morals kick in. Policy that involves patient care should be centered around the patient. However, many times these patients lack the access or knowledge to benefit from a certain policy. Monetary issues play a large role in the implementation and development of policy as well. Where money comes from can influence a policy to benefit one group over another, and a lack of resources can result in a poorly constructed policy altogether. First, we will discuss the background of the policy at hand. From census data collected from October 1st, 2017 through December 31st, 2017, the United States reported 52,878 applications being received from refugees and those seeking amnesty. A large portion of these applications were approved, while a small portion was denied. However, there are still 138,019 applications pending at that time. During the same time frame, in North Carolina, 145 applications had been received, 363 had been approved, but there were still 602 pending. While the number of applications approved seems impressive, the number of pending applications is staggering but unsurprising. Individuals hoping for citizenship must complete several, sometimes lengthy steps to be eligible to apply. First, the individual must be 18 years of age or older. They must be a lawful permanent resident, which means they need to obtain a green card. They need to have lived in the United States for 5 years consecutively, or 3 years if they are married to a U.S. citizen. And before final application, they must show proof of residency in the same state or district for 3 consecutive months. After this is complete, an N-400 application must be filed. The processing of this document can take 6 months to a year or longer, depending on the number of applicants in a given area at that time. Once the application is received and there are no mistakes found, several appointments will be made, including a biometrics appointment where the refugee will be fingerprinted and photographed, and a naturalization interview. If the individual passes this interview, they will be scheduled within approximately 6 months to take part in a naturalization ceremony to become a U.S. citizen. This entire process can take anywhere from 18 to 24 months or longer. Many refugees cross the border burdened with chronic medical conditions. These conditions, whether or not they have been properly managed in the past, need to be addressed as quickly as possible once these individuals enter the United States. This can oftentimes prove to be difficult because of lags in healthcare for these patients. As I'm sure you are aware, the refugee influx into the United States is causing quite a stir among politicians, healthcare workers, case managers, and many others. With this large amount of refugees comes a greater need for healthcare providers to assess and care for these patients. Many refugees cross the border without life-saving medications. This can be due to multiple factors, including fear of bringing drugs across the border or having to sell medications to assist with travel to the United States. Delays in health assessments and screenings can sometimes mean deadly consequences for these patients. This can lead to emergent medical conditions arising quickly and without enough resources. Many times, resettlement affiliates find themselves paying for medications until health care can be established. Among the chronic conditions that refugees enter with, mental illness and mobility issues are two of the most common and most costly to the U.S. health system. Next, we will analyze the policy. Refugee medical assistance is provided to those who enter the U.S. legally, but is limited to 8 months after entry into the United States. Individuals enrolled in this program are either beneficiaries of North Carolina Medicaid or North Carolina Health Choice. North Carolina Health Choice differs from Medicaid in that it does not cover children less than 6 years old. It also does not provide services for long-term care or non-emergency medical transportation for children or dependents. It also only offers those individuals dental service on a restricted basis. Within the first 30 to 90 days upon entry into the United States, refugees receive one free health assessment. Medicaid or North Carolina Health Choice covers services for beneficiaries during the following 8 months. According to the policy, these services should meet but not exceed the needs of the beneficiary. Services rendered by providers must be the most cost-effective option and must not be performed for the convenience of the patient alone. Refugee medical assistance is offered to an individual only once per lifetime. There are some successes to this policy. Without it, there would be no screening process for refugees upon entrance into the United States. These screenings, while they do vary from state to state, usually involve some sort of testing for infectious diseases, immunizations as needed, a general health physical, assessments regarding tobacco, alcohol, and illicit drug use, and health education. However, there are major pitfalls that should be addressed with this policy. Many of the initial refugee health assessments are performed by third-party providers who are not primary care practitioners and oftentimes do not refer individuals to a primary care office following the initial assessment. This leads to a discontinuity of care for the patient. Also, because of this and low reimbursement rates from Medicaid, many providers are shutting their doors to refugee health due to unrelieved financial strain. Finally, by not covering mental illness, this policy does a disservice to not only the patient, but the providers who do not receive reimbursement for the treatment of a very prevalent and expensive disease. A proposed solution to one of the issues in this policy, which is being trialed in other states across the U.S., would be to have primary care providers in the area complete the initial health assessments on refugees. By doing this, that provider would receive the initial reimbursement from Medicaid to assist with financial burden and can develop a better relationship with the patient and encourage a stronger continuity of care. Also, many refugees are unaware that they may be eligible for some sort of aid after their initial 8 months in the United States and go without medical care after this time. By having an established provider that they trust, they may have more knowledge regarding what step to take to ensure health coverage. So how do we make this initiative happen? There may be many providers in a given area that are unaware of the opportunity of performing these assessments on refugee patients. Making this knowledge public information could assist in piquing interest of providers in that area and hopefully increase the number of health assessments performed by primary care providers in local health departments. For those providers who do not practice in a health department or who do not offer their services occasionally already, contracts could be made with local health departments to allow these primary care providers to perform initial health assessments at the health department. In exchange for performing these assessments, providers who utilize this initiative and transition these patients from health departments to the primary care office would have the opportunity to offer assistance to the local health department in whatever way they could. This would also lessen the burden on providers at these departments who may be overwhelmed with refugee health. Some potential obstacles for the implementation of the proposed idea could be a lack of willing providers in a given area to accept refugee patients. This could be stemmed from the stigma surrounding these individuals as well as past experience regarding reimbursement. Also, those providers who are currently performing these assessments that are not primary care providers may offer some resistance to this change. Both issues can be resolved using communication and teamwork. By stressing the importance of continuity of care and reimbursement to the primary care providers, hopefully they will open their doors to these individuals. Without this process, they will more than likely see these patients at some point or another along their 8-month journey under this healthcare program. And if they are not the ones to complete the initial health assessment or do not have an established relationship with this patient, providing adequate care may be time-consuming and inefficient for the patient. Third-party providers could still remain relevant to refugee health care. Depending on the area and how many refugees are present, they should still be encouraged to complete assessments on those who cannot see a local primary care provider quickly enough. However, they should also be encouraged to share documentation with the providers that will eventually assume care of these individuals. One way to evaluate if the implementation was successful would be to look at the reimbursement rates for specific primary care offices before and after the implementation was introduced. This would show whether or not the Medicaid reimbursement from the initial health assessment is minimizing the financial burden of the following 8 months of care for patients. Also, by comparing ER and urgent care visit rates before and after the implementation, one could hopefully observe a trend of less utilization of acute care centers for primary care needs.